during the Q&A session, please use your raise hand function to request the floor. And before you ask your question, please provide your name and affiliation. And for the Q&A session, I just want to emphasize, we are trying to do something a little bit different where people just don't simply ask the questions in the chat box, but we do want to give you the floor to directly ask the innovators the questions that you have. One, it is really to make this a little bit more interactive. And two, sometimes when the questions are asked in the chat box, we don't have a full picture of the actual question you're answering or asking, and so we're probably doing a disservice to the question that you're asking. So I think with that said, I am going to give the floor to Chris. So Chris, maybe I can stop sharing my screen and give you the opportunity to share your screen. Perfect.
Okay, can you see that?
Chris, the floor is yours. Yes, please go ahead. It's show time.
Okay, great, thank you. Let me just hide the controls so that I can see my own slides. Okay, good afternoon or good morning or good evening, everybody, wherever you happen to be here in the pandemic. My name is Chris Masick, and I'm the CEO of SystemOne, and I'm happy to have a chance to talk to you today about connectivity. I'm going to talk about connectivity in general and how we view it at SystemOne. And again, the title of the talk is Connectivity for Real-Time Diagnosis to Manage TB, HIV, and COVID-19. And we'll talk about those things.
Okay, Chris, so, maybe you can speak a little bit louder.
Yeah, okay. Thank you, Jackie. The objectives for this meeting, I'm just going to give a quick introduction of myself and SystemOne. I'm going to give a quick primer on what connectivity is. I'm going to give a vision of something that we call diagnostic accountability, which is a way to view the health system from the lens of the diagnostic network, the lab network. And then we're going to end with a suggestion or a way to position countries for COVID-19 testing and strengthening their TB diagnostics at the same way. Okay, I just want to give a little bit of background of myself and our country. I'm the CEO of SystemOne currently. I'm also one of the founders. So I had started SystemOne about 7 years ago. We built GX Alert, which was our first platform. Many of you may know it or have heard of it or maybe in use in your countries. Over those 7 years, we've connected about 45 countries in one way or another, over 3,500 labs, most of those gene experts, but also Abbott M2000 labs, Roche Cobas, Lear Qs, several other diagnostic instruments in use. And during that time, we've moved about 10 million TB results worldwide. So we have a fair bit of experience in lower middle income countries, a fair bit of experience with a number of different diagnostic devices and diseases. But I'm going to speak primarily to our TB experience given the Stop TB Partnership context. Okay, I want to give a quick overview on how we look at connectivity at SystemOne, and this has evolved. It's not our own view. I know the whole field has evolved over the past 5, 6, 7 years. And what people are doing with connectivity and why they're connecting instruments is changing a little bit. And I'll sort of just show the way we see this. So I understand connectivity is 3 components, basically 3 steps. And the first one is to connect the instruments. And those are typically in the labs or point of care, near point of care. The second step is to report those results back to the clinics, the healthcare workers, and the patients that have sent off to those labs for the tests usually. And then we have a third step here that we call confirm the follow-up. And I'll talk about that when I talk about the diagnostic accountability a little bit. And that's basically accounting for the fact that the diagnosis was done in the lab, the test result was generated, that result was reported back to the clinic, and that something was done about that result, or that result was just minimally that it was received, but there can be more done with that, and I'll talk about each of those. I like to just give a little bit of context to why connectivity is still necessary and one of the problems the basic problem that we're solving with connectivity is really to make the data digital, to make it electronic. Therefore, it can be transmitted almost instantaneously. It can be copied, it can be aggregated, it can be distributed much more easier than paper. This picture here is a moment I had in Nigeria where I happened to go into a gene expert testing lab and come upon this moment.
Chris, I'm
Yep.
so sorry. People are still having difficulties hearing you. So
Okay.
I wonder if you can talk louder or if there's any way to increase your volume.
I'm going to
switch out of my headset.
Oh, that is so much better. Oh, that is so much better. Yes.
Okay, good. So I'll just be speaking right into the computer.
Yes. And then like talk loudly, emote.
I'll just turn my speaker down so I don't hear you too much. All right, so I was mentioning the paper was here. I came upon the scene where the regional local government supervisor actually had stopped by the lab to copy the lab results from one paper lab register to another paper register. And again, in the old days, I would almost call this the Stone Age. This is how information traveled. It was manually written down, transcribed from book to book, but this is still actually happening in some of the countries we work in some labs. The other thing that we notice is that, you know, typically when people are thinking about fighting TB or ending HIV or now with COVID, they think about it as a medical problem. And one of the things that we find is that most of the people in the WHO, in the ministries of health, at the Stop TB Partnership, you know, all over the global health scene are doctors. You know, they come up through the ranks, they're trained as doctors, they view the problem as a medical problem. When you're trying to treat 10 million people with TB, or 1 million people in your country, or an unknown number with COVID, it's as much of an information problem as it is a medical problem, or I would contend that. And when you're trying to deal with it on a national or global level, you have to deal with it. Let's put it another way. If you don't deal with the information problem, you can't deal with the medical problem. So let me just go ahead, and connectivity is one of the ways that we solve that information problem. And let me just, maybe I'll say, disclose here, I'm not a doctor. I don't have a medical background. I come from the technology side of things. I'm actually a computer developer by training, but have come to this field from the IT side, the information side. All right, I want to get a little bit into the nuts and bolts of what we do. I mentioned 3 parts of connectivity. The first one was to connect the instruments. And, you know, it's pretty simple what we do. We take, you know, the instrument, say a gene expert is in a lab or a clinic, and you connect that instrument to the internet so that it can transmit to a server. You know, I'll call this say our GX Alert server or Aspect server, a place to receive that result. That server is typically in the Ministry of Health, typically maybe in the capital of a country, but it's also possible to serve that in the cloud. And we can talk about which is more secure in a minute. But the basic idea is that as the instrument is operating in real time, those results, when the test is completed, can be sent over the internet to a server. And from there, we can take the next 2 steps, the reporting and confirming. Frequently, almost before the lab technician in the lab, if this is set up correctly, it happens automatically. As soon as the test is finished and before the lab tech can even print it out, it has been transmitted through the router, modem, whatever, over the internet and to the server, and maybe already sent to the clinic or whoever else needs to receive that data. So if it's set up how we like it to be set up, in real time and automatically, those results just move as fast as they are done on the machines, you know, sort of instantaneously transmitted. To get down a little bit to the nuts and bolts, so typically there's not, let's say in some cases there's internet available at the clinics and the machines can rely upon hospital internet or lab internet. Typically that's not the case where we end up working, and we install some kind of modem and a SIM card. We like to put a kind of beefier modem as opposed to a little $20 thumb drive, only because that modem is sort of hardened, ruggedized for the climates that we're often in: dusty, hot, humid. And we can also give a SIM card where we can control the data limits, because if you provide internet to a remote area, you have to make sure people aren't using it for Facebook or YouTube and sort of eating away all your bandwidth. You also need to limit which sites they can go to, again, to secure the data, make sure it's only going to the places you want it to go. So we typically put a hardened router in there. It's about $200 US. It's expensive, but it comes up automatically with the power. If there's a power outage, we can remote into it from afar to troubleshoot or fix, support it. We usually recommend a global SIM, but it's also possible to do a local SIM. And we often have an external antenna so that we ensure that there's signal. And even in sites where there's only a weak 2G connection, we're still usually able to connect an instrument and get that data moving to our server. Once you connect an instrument like that, it's kind of like turning on the lights. The connectivity basically provides a transparency into the diagnostic network, and it shows us two kinds of data when those machines transmit a test result. The first is the clinical data. So obviously we get the result of the test. And often with that, there's a sample ID, a patient ID, something that identifies that result to the patient. Additionally, we often get other associated patient data. In many countries, there is no unique ID, so sometimes we'll have the name of the patient, sometimes their address, sometimes their cell phone, sometimes we get the clinic that they received their treatment at, sometimes the reason for the test. The other thing we get is operational data. So we can see information about the machine, things like utilization of the machine, number of tests run per day, number of days running per week or per month. We can see service or repair issues if machines are down, and we can help coordinate that. We can look at the cartridge inventory supply. So our system, we know that each test, for instance, takes 1 GeneXpert cartridge. So if we know the total number of cartridges at each lab, we can just subtract one each time we have a test and see when people are getting close to running out or expiring. We can also look at the errors in the performance of the machines, how they're doing. If a machine starts, throwing errors every 10, 15, 20% of the time, you have a definite service and repair issue there, and we can notify the service people. So I mentioned those three things: connect, report, and confirm the follow-up. So if we had Aspect as our central platform in the country, the first thing we would do is connect those labs using those routers or modems we just talked about. We can connect a number of different instruments, and this can be for different assay types and diseases. So currently, TB is a pretty typical one, but we're starting to use the Ultra cartridges and now soon the XDR cartridges. But we also connect the BD Midget, for instance, for the second line testing, some of the Abbott and Roche machines for viral load, really for anything, any kind of diagnostic or test result. After you connect that device and get the results to a central location, you need to report that data out. So some mechanism to get the results back out to the healthcare workers, back out to the clinics, back out to the patients. And one of the things that we typically improve when we work in a country is the turnaround time. And we've seen turnaround times on GeneXpert labs upwards of a week, 2 weeks, sometimes even longer. In the HIV viral load central labs, those can take up to 2 months to get a test result back. And again, there's very little visibility in most of the countries we see in getting those results back. There's some number, 10 to 20% never even make it back to the clinic for whatever reason. And there's a lot of kind of unknown about what happened from the clinic side once they send a sample out to get tested, if and when that result will get back. So we can send directly to the clinics via SMS, email, or mobile apps, and I'll talk about that in a little more detail. We can also send directly into EMR, EHR systems. So LIMS systems, OpenMRS, DHIS2 are a couple of examples of the kind of systems we connect to, but any electronic system. Getting some confirmation of treatment or follow-up back, and I'll talk a little bit more detail how we do that. But we get the results from labs, we send it down to the clinics or to the electronic systems, and then get some signal back that there's been some treatment. And then based on that, we can look at what percentage of the test results from the point of view of the diagnostic network have actually had action taken on them. So for instance, high viral loads, has there been some adherence counseling? Has there been some referral for second line or third line drugs if we're not getting the viral load count down? For TB, if it's a positive TB test, has the patient started treatment? If it's a RIF resistant test, are they on appropriate treatment for drug resistant? These are the kind of things you can look at and measure either at a national level, at a state or provincial level, down to a district level. You can do individual labs or individual clinics. You could slice this by children and adults, men and women, different groups, again, depending upon what you have coming with your patient data. I mentioned reporting, and we originally were using SMS and email to report the results back to clinics, and we can still do that, though we have since developed an app, an Android app that we call our Aspect Reporter. This allows us to automatically send the results in a more structured form down to, say, the DOTS officers in the clinics. And we know from the test result which clinic that patient gave their sample from or where they received treatment from. We can send those results right back. And then we keep track. This is the sort of confirmation or accountability piece. You notice this awaiting treatment, how many days. Because this was a positive test result, we're looking for some indication that that patient was put on treatment. And when a person in the clinic receives a result, they have a button they can click on that just says clinical response, and they can indicate what treatment they started the patient on, when that patient started, and or eventually an outcome for that patient. This allows the clinics to confirm the treatment, not only receive the results, but confirm the treatment. The app is designed to be secured and work online or offline or intermittent availability. And it's easy to distribute because it's right through the Google and Apple stores for apps. What we found is that by using an app as opposed to SMS or email, there's a number of advantages, and I'm not going to go over all of these, but we still have the option to go through email or SMS if we have to, but for those people in the clinics that do have access, or if there's a tablet or a phone, dedicated to the clinic that runs the app, you can just send the results directly back there. I want to talk in the last couple minutes here in my presentation about what I think the real value of connectivity is, and this is dealing with the problem of loss to follow-up, and this is, I'm speaking here to the pre-treatment loss to follow-up. I'm citing here a couple of studies that were done over the past 10 years on a few different countries, where they looked at the number of people that had a confirmed diagnosis, but never made it onto treatment. And so I'm showing this DX bar here, this diagnosis database. Maybe in your country there was 50,000 positive, gene expert confirmed TB cases. But in that same period, maybe there's only 35,000 people on the treatment registers or rolls. This is a typical differential and problem, and varies by country, but all countries seem to have some significant share of this loss to follow-up. And again, because many of these countries have no unique ID, there's no way for a computer to reconcile easily this 100,000 diagnoses with this, 35,000 or 50,000, whatever it is, people on treatment. So one of the things connectivity allows is a way to tackle this problem. If we look through the lens of the diagnostic network, it's sort of like, over on the left here, I can see from the diagnostic lab network how many people are being positively diagnosed. And this could be for TB, this could be for high viral load, this could be for COVID, whatever it is. Those people, after getting diagnosed, still have to make it over to the treatment side. And this is where that loss to follow-up, it's almost like they have to make this bridge, this link from lab to clinic. And how do you ensure that this link happens? Typically, again, 10, 20, 30% of the people, even after diagnosis, aren't making it to the treatment. They're sort of falling off the bridge here through the cracks in this loss to follow-up. One of the things that's possible, again, through this lens of looking at it from the diagnostic network, and again, we call this diagnostic accountability, is that we can keep track of all of the people that were diagnosed, each diagnosis, and then confirm that they had some appropriate follow-up. And that the way our system does that is that it lets the country define how they want to confirm follow-up. So there's different methods to confirm that, and there's different criteria for what they consider confirmed. In some countries, it might just be if the result arrives at the clinic and the DOTS officer or the clinician says, I got it, that's enough. Confirmation that it was delivered, sort of like receipt confirmation. Another country might want to indicate that that not only is the clinic receive the result, but that the patient is put on a treatment, just confirm that they're on treatment. Another country might want to know when they started the treatment or what the treatment was specifically. And again, we can make those kind of options available at the clinic level when we're showing the results and reporting the result, again, getting those options right back to the people. I mentioned that it's very difficult, perhaps impossible, to reconcile these two databases due to the lack of a unique ID. That's true at a national level, that's true at a computing level. However, it's not really true at the local level. At a local clinic, maybe they only see 10, 15, 20, 100 patients a week. Just using the name, if I sent a test result out last week or 2 weeks ago and I get a result back and it has the name and I look at my register and I see the age or whatever confirms it, a local DOTS officer can uniquely figure out who that test result is referring to and do the treatment. So when we give those local DOTS officers these results, again, through this app, and let them be the one, because there's a human there that can make that sort of human connection between the diagnosis, the lab result, and the patient on treatment. There's sort of the bridge that can connect those two. It allows us to make that connection and measure that loss to follow-up. And so we know all of the positive diagnoses that have been confirmed or followed up, and we also know the ones that haven't been, and we can keep prompting either with, in our app, we sort of have a red, yellow, green for the clinical worker to continue to follow up until they've confirmed everybody that was positive. And again, this could go for COVID, this could go for high viral load, this could go for TB or drug-resistant TB case, pretty much anything that that you're testing for and moving through the diagnostic lab network. Okay, I'm going to pause there. I know there's probably some questions, and I went through that pretty quickly, but we want to leave a good amount of time for some questions and discussion. I'm going to turn it over to Patty at this point to talk a little bit about what we've done to extend for COVID testing and prepare for that.
Thanks, Chris. Yeah, so the question right now with the current COVID-19 pandemic is how to leverage these existing technologies that we have to support the continued essential testing for people affected with TB or HIV and other diseases, and maximize the ability to jointly test for COVID-19. So SystemOne has developed a compatible module to collect COVID-19 testing data, as you can see here, both on our platform, on our dashboard, and on our mobile application. And it is compatible with Cepheid's GeneXpert cartridges, as well as other rapid point testing for COVID, including the Abbott M2000 and others. So next slide. So we obviously share the valid concerns of potential diversion of resources from TB testing to the current urgent COVID-19 testing. So SystemOne data scientists undertook an analysis to understand current utilization rates of GeneXperts connected to GXalert or Aspect to see what this increased requirement for testing will mean for a lot of countries. For this analysis in particular, we used data from 618 GeneXperts across 8 countries. This analysis is also up on the website in case people are interested in looking a little bit further into these graphs. But the assumption that we used was that a laboratory can run about 3 tests per module per day over 21 working days. So we calculated an instrument's yearly utilization rate, given that the number of tests run per year, and then divided by the theoretical maximum number of tests an instrument could achieve in a year. And given that the findings showed that only 10% of this sample of instruments are reaching utilization rates of above 80%, which means that over 75% of instruments are performing at below 50% utilization rates, which is encouraging in the sense that we do have increased capacity for the COVID-19 testing that will be increasing over the coming months. But it is a matter of utilizing this kind of operational data in order to be able to plan for this increased testing and this switch in terms of encompassing COVID-19. And another analysis that SystemOne data experts did, in addition to kind of enable for preparation was analysis that was focused on whether these gene expert machines were actually COVID ready, that we call it. And what that really means is that the new gene expert Cepheid test for COVID-19 requires or only operates on a gene expert software version of 4.7b or later. And this is something to note because obviously to upgrade to later versions in order to be compatible with these new COVID-19 tests, it requires, you know, some careful planning in terms of time and costs implicated, human resources, etc. So we did an analysis of 18 countries, about 594 gene experts, and the news was the findings were encouraging that many are, you know, upgraded and ready for this influx of testing once the cartridges reach countries. But however, there still is, you know, 12.6% of sites that require this upgrade. So this and the other information, both analyses, are up on our website, and we encourage you know, folks in the room right now listening, if this is interesting and if you require an analysis, SystemOne data analysts would gladly be able to do an analysis for your country to determine whether you are readily available for COVID-19 testing.
Okay, thank you, Patty. And thank you, everybody. And Jackie, so we're ready to stop and take questions.
Perfect. So, yes, Chris and Patty, thank you so much for your presentation. And for those who want to follow up with SystemOne, please note their contact details and follow up with them directly. I mean, obviously, you can also reach out to the Softy Partnership and us to follow up. So this is actually the favorite part of the Virtual Innovation Spotlight, the Q&A session, because I kind of call it the Shark Tank of our event. And we really want, I'm the queen of bad television, I'll just tell you that. But you know, we really want people to be able to directly ask the innovators who are presenting the questions directly. So I would actually love to open the floor right now. If you do have questions, can you use your raise hand function so that I can see that you have questions, and then I will give you the floor. I will ask you to introduce yourself, your name and affiliation, and then ask you to ask Chris and Patty and Brad. I think Brad is on as well from SystemOne on the question. So with that said, does anyone have any questions? If you do, please raise your hand. Okay, Robert, you have the floor.
Thanks, Jackie. My name is Robert Makombe. I'm working with FSI 360. I'm based in Pretoria, South Africa. Thanks for these great presentations and for this webinar, which really comes at a very opportune moment. My question is just a quick one. It's great to see the utilization rates of gene experts and so on, but since this actually measures the results of several intersecting factors in the TB diagnostic network, you know, like your algorithms, your specimen transportation, your human resources, your distribution, and so on. My question is, how much attention really should countries give to this measure? Because we often know it's used as a very important measure, particularly now as we're moving towards the last mile of our TB detection. Thank you.
Great, thank you so much, Robert. So Chris, Patty, and Brad, do you want to take a stab at Robert's question?
So I just want to make sure I understand the question. I know you referenced a number of different things that affect the treatment of TB and the detection of TB, and how much should we pay toward this, you know, the utilization rate is a factor. I'm not sure. I think if you don't measure it, you can't improve it, would be my basic approach to start with. And that as soon as you start measuring it, you can get a baseline and then start to see some of the details about what's keeping utilization down or why it's down in certain parts and not other parts. Is it because it's not being supplied? Is it because there's staffing issues and people can't run the machines? Is it because there's a sample transport issue and they can't get samples to that area, or the surrounding clinics don't know about that lab and so they're not referring to it? But I think until you get the basics of sort of how everything is performing, kind of basic, that idea of turning the lights on and getting that transparency, you can't even begin to ask those questions or see where to put your attention or resources to try to improve that. Did that answer your question, Robert? Or did I understand the question correctly? Or Patty or Brad, did you hear it differently?
Yeah, I can probably add to that. Can you guys hear me okay?
Yep.
Yeah, I think, in terms of the utilization measure that we presented there, we're not trying to provide insight into how effectively a TB program or an HIV program are utilizing their instruments. I think we're really looking to answer, one of the initial concerns around the COVID-19 pandemic was that institutions may need to purchase additional instruments to do a lot of the testing, and we just want to have a look into that and show that while this isn't a measure of how the health system works, that there is existing capacity with the current footprint, and our recommendation is really to look at the existing capacity you have rather than trying to prioritize buying new instruments to augment the testing at the moment.
Okay, great. Thanks, Chris and Brad. And it looks like based on what Robert is saying in our group chat that you guys have covered the question. So, Elaine, I'm not quite sure if you're able to ask the question directly. I see you did ask a question in the group chat, so maybe I'll ask and then please clarify if we're not correctly understanding your question. So Elaine has his or her question is, can you give us more information on the data presented by Patty on the name of countries which are ready to run COVID testing, and are there costs for moving from GX Alert to Aspect? So I think Chris, Patty, and Brad, you can see the group chat question, and if we do have any clarification, we can ask Elaine to maybe clarify as needed.
Yeah.
So, go ahead, Patty.
Thanks. In terms of the data that I presented, Elaine, feel free to reach out. I mean, I don't have the countries in front of us, and honestly, our data scientist, Natasha, ran the numbers in terms of the countries that she used. And of course, we wouldn't want to share that right now here, but feel free to reach out. But in terms of the costing, I'll let Chris, but just to, before Chris takes, in terms of the costing, we can have the COVID-19 module on GX Alert and Aspect. So there is not necessarily a requirement to move from GX Alert to Aspect, although there is obviously a lot of, in terms of Abbott M2000, other kind of devices that are being used would be accounted for with the Aspect platform.
And maybe, Chris, before you answer, I think this is a really important question because it has come up a couple of times now in our different BISs. Countries are in the process right now of not only trying to use their current allocation to mitigate any interruptions in TB services during this COVID-19 situation, but they're also in the process of submitting their next global funding requests for the next allocation period. In order, as part of that process, they do need to give a budget range. And so I think this is why this cost question comes up quite often. So I just wanted to put that in context before, Chris, I give you the floor.
Thank you, Jackie, and thank you, Elaine, for your question. So just to reiterate what Patty said, I think what we're seeing from this analysis is that there's not certain countries that are ready and not ready, say, to utilize their gene experts for COVID testing. What we're seeing is that 1 in 8 of the machines that are in any given country are older and are still running an older version of the gene expert software. And so we're just giving a heads up to countries that as they start to plan which gene experts they're going to include in their COVID network for testing, that they make sure they account for the differences in versions and that they are either choosing machines that are already capable of 4.7B or above, or planning to upgrade the version of those machines, the older machines, if they have to use them. As far as pricing goes, and I may ask Brad to step in here too, but the general understanding at SystemOne is that If a country is on contract for GX Alert and using it with us, they get a free upgrade to Aspect. If they're not on contract and they're using an older version of GX Alert, they would need to purchase that or come back on contract to get the Aspect version. Brad, you want to add anything to that?
Yeah, that's correct. So any countries that are currently on contract with us will automatically be migrated to Aspect. We also know this, isn't a quick process because countries have invested quite a lot in getting the user base trained up on GX Alert. So that is a process that will take them through during the contract phase. And we're happy to put some quotes together. Again, it's not a universal price. It depends on how many instruments the countries has. So if there is any interest in looking at the pricing, please do feel free to reach out to myself, Chris, or Patty, and we can get those turned around for you pretty quickly.
Okay, great. Elaine, I just hope if you can either jump in or text. I mean, did we sufficiently answer your question?
I see that she actually, we'll see if she can jump in.
Yes, but we will actually collate the chat summary and the questions that are being asked and give Chris, Patty, and Brad an opportunity to write responses as well, and we will post them on our website and share them with folks. So, okay, so now Oriel has asked a question as well, and I am really sorry if I'm mutilating people's names. I am very bad these days with that. I think it's age. I'm 43, by the way, just in case people think I'm actually 23, because I'm not. Okay, so with that said, Oriel's question is, how long does it take for Cepheid to upgrade software to 4.7 or higher? And what are the costs and local requirements for that upgrade?
I wonder if there's anybody from Cepheid on the call that could answer that very definitively, authoritatively.
Anyone from Cepheid or anyone who knows Cepheid, or can you? Is there anyone who can jump in? Maybe. Let's see.
Brad probably has a pretty good idea.
Okay, Brad. Maybe Brad. We'll put you on the hot spot. Apologies.
I mean, yeah, we definitely can't speak on Cepheid's behalf. It really does depend on the level of agreement that they have in country and whether there's a local service provider. In terms of actually doing the upgrade, it's about an hour. It does need the instrument to stop running, so they do need to do some maintenance on the instrument. They do need to stop testing, and then they can do the upgrade process. How long it takes to get a technician to the facility, I think, is going to be very variable on country, and whether that is free or charged. Again, I think it's going to boil down to whether or not you have an active agreement with Cepheid.
So Oriel, did we, I mean, apologies that we can't maybe sufficiently and directly answer on Cepheid's behalf, but it is something that what we can do is circle back with some of the Cepheid's representatives that we engage with and see if this is something that they can answer. I guess Oriel's like, but does it require a personal agent in the facility? And okay, so this is really great. So one of the things that I did want to ask, again, as part of this whole like global fund processes related to the current and future allocation is, what are the different types of implementation related activities and costs that countries need to consider to roll out SystemOne? It is something that came up with the AI for chest X-ray, medical imaging, VISs. And so, I think these are things that countries need to know. So what are some of the other, activities and costs that they need to bake in related to, introducing and scaling SystemOne's solutions?
Brad, do you want to take a stab at that?
Sure. Yeah, in terms of working with the ministries of health, we try and take a model where we build as much capacity as we can so that they're able to sustain the system moving forward. So typically we'll go in country, we'll work with the group and co-connect the first couple of facilities together We've gotten our installation process down really quickly. I think we've got a couple of our colleagues on from Ukraine, Lexi, I see you're on here as well, who can also attest to being able to do this remotely. The installation process is really simple. It takes between 5 and 15 minutes to actually install the software and get it up and running. But yes, it does require a visit to each facility. So typically we either work with countries on putting together an installation plan and working with a local partner to do that, or helping schedule this in with their routine lab visits. I mean, typically there is somebody who's going to one of these facilities at least once a month for some kind of routine care. We don't need an IT person to do the installation. This can be done by a lab level or by a project management level person. So there is travel involved. There is some also training that needs to be done at the facilities. So, making sure the users are aware. You get a lot better user buy-in from the system. When they're aware of what benefits the system can give them as well. So, making sure that the lab tech understands what's being installed, why it's being installed, what information are they being asked to collect additionally, and how is this going to benefit them, we found really results in a much better performing system. If somebody just comes in and installs something on your computer, it doesn't talk to you, you've now got a weird router that you've never heard about. Those typically get packed up, boxed away pretty quickly because people don't really understand, the purpose of the installations. So there is some site visits required, and of course, troubleshooting. So, just really trying to figure out, what are the basics to look for when something's not working, and getting, the minimum information you need so that you don't have to do too many site visits.
I would add one other thing. I mentioned before that, for the connectivity to work, not only do you have to provide some kind of internet access or network access at the instrument or lab level, but you need a server or someplace to host the platform, either GXLR Aspect or Data to Care, or whatever your connectivity platform is. I talked about the difference between running that in country or in cloud, and both are options I think that we offer. I know we offer it. I think other providers offer that as well, that choice. But what we see a lot is the countries either have laws or just feelings about the need to keep the data in country, and having the server in the Ministry of Health, for instance, or in the capital, someplace like that. But I will say that we have seen again and again problems with in-country servers. Just yesterday, we had a country that their whole health, some portion of their health IT infrastructure got hacked by ransomware, and is now being held, sort of inoperably and held for ransom by some, computer hacker terrorist kind of group. And some people think the data is more secure if it's within their national borders, but with the internet, that's just not true. I will assure you that Amazon is doing a better job protecting and monitoring their IT resources than most of the IT techs in the countries we're working in. And I bring this up just because it's another thing that countries will need to consider, and it's a cost, either a server in country or a hosting cost in some kind of cloud. And some countries are fortunate enough to have good, strong cloud infrastructure in country, so they can still keep the data in country, but not have to rely on the TB department to manage servers or something like that. Anyway, I'll stop there.
No, and Chris, I think you bring up a really good point, because I think this kind of in-country server versus cloud debate is something that, is coming up quite often across different digital and health tech solutions, not just obviously connectivity solution. And, I think like countries, obviously, I totally understand why they would prefer in-country servers. It's related to data privacy, et cetera, et cetera. I think, it's something that maybe the SOP2 partnership should kind of look into in terms of, okay, we don't want to dictate to countries which kind of systems they should use to share their, to store their data, to collect and store their data. But I think it would be good to have this discussion further, because This is like an infrastructure question, you know, in order to kind of scale these types of technologies. This is like a big question that we keep on coming across over and over across different digital and health tech solutions. So I think this is a really important question that we do really need to further discuss and figure out at some point. So Robert, you have another question, which is fantastic, even though I would wish you would just ask it directly because I have to read it off this chat box. But Robert's question is, Aspect will meet a growing need. From your experience from around the world, are you able to say how well multiplexing is working? And in particular, if there are any issues with maybe the lowering of the priority to test TB?
I'll say that even though I've seen a lot of preparation by countries, for instance, to use gene experts and the Cepheid COVID cartridge for COVID testing, that I have not yet actually seen any of those cartridges in country. So I can't say how well that's working. I have seen gene expert networks also running other kinds of tests like EID tests or viral load tests, sometimes HPC or HPV in certain countries. It can cause some challenges only because then you've got different departments that need to work together. Typically, what we see is that the TB departments often take some ownership or the position of ownership on the gene experts and are somewhat territorial about them and are concerned if other groups start using them, but they're not paying for the service or the warranty or the initial purchase of them, so that they're losing some capacity. But I've also seen other countries looking at their utilization, you know, fairly objectively and saying, well, okay, so we have this spare 30% capacity. If you want to do X, Y, or Z on it, that's okay. Why don't you also do some share of the service or support? And you know, now that Cepheid has moved to that access care model where the service component can be bundled in with the price of the cartridge, then the HIV cartridge or the HPV or the COVID cartridge, each could have some portion of that cost. And we're actually working with both Cepheid and some of the global donors and pricing mechanisms to see if we can find a way to price connectivity that way as well, that you sort of buy it as an add-on to the cartridge so that you know each cartridge will be followed through and basically get this audit log that it was used, where it went, what the result was, and what, if it's a positive result, what the follow-up was, that accountability on it.
I would just add to that yeah, I think that we see, you know, the shift from disease programs not being so siloed and for them to have these integrations. And just to reiterate, Chris, in terms of the pricing, one other thing that we're actually exploring, as I mentioned with the COVID-19 test, we're going towards per test pricing. So that will hopefully encourage, you know, if there is spare capacity and on a gene expert and TB test could be per test, and then per test pricing, and then have that extra capacity go towards viral load, let's say. So there's, you know, there are ways to go around in terms of encouraging that kind of integration, whether it is a bottleneck of pricing, let's say, or costing.
Great, thanks, Patty. So I see Paul has his hand raised, and you know, Paul, he probably doesn't remember this, but I was in a meeting with him years ago when Stop-T Partnership was at WHO, and you know, he's just like this very articulate, eloquent man, and I remember he used this as a phrase like, "Alrighty, let's get the show on the road," and I actually still use that. So Paul, the floor is yours with that introduction.
Well, thank you very much, Jackie. My name is Paul Nunn. I'm a consultant from London, and I do a lot of national program reviews. And in pretty much all the countries I've been to, gene experts are insufficiently utilized, even by the TB program alone, never mind by anybody else. And I think, Chris, you're pointing out that you need to get into the basics of why they're not being properly used is really important. And one of the key ones, I think, is that there's often confusion around the policy. Are they being used to confirm drug resistance? Are they being used to diagnose TB? Who is supposed to be ordering the test? Often the clinicians are reluctant to order the tests because they know they're expensive or for whatever reason. often to do with confusions around policy. Oftentimes the lab techs are only working 2 or 3 hours a day, so there's only one cycle done a day, and that's to do with remuneration of low-paid staff. Many times there's broken modules that haven't been properly fixed and so on. So I think we really need to get into those details. But it's really nice in the presentations to hear how all this is, how all the sort of interconnectivity of diagnosis and the possibility of connecting it with treatment is being brought together. We've been postulating and hypothesizing how this could be done since Expert came in. So that's nearly, what, 12 years ago or something. So it's good to see that there are models, but I'd like to hear of a model country where this is actually working, a low-income country. And I'd also like to ask that, given that the diagnostic algorithm now in most countries for TB includes chest X-ray, or if it doesn't, it should, and many of the chest X-ray machines are digital, I assume that there would be possibilities of linking up digital X-rays with such a system. And again, do you know of any examples where this is being done? I mean, there's so many wonderful possibilities here, but I think countries are very slow in utilizing them. Thank you.
Thank you, Paul. It seemed like so you said a model country where all this is working. You know, I don't know if we can find such a country, and I'm not sure what the standard for working would be. They all function to different degrees in every country, but there's certainly room for better utilization and better coupling between diagnosis and treatment in all the countries that I work. In terms of the digital X-ray, we've actually started working with Delft, for instance, in their CAD for TB. We're starting a pilot project down in Nigeria where the protocol will be to do screen with the digital X-ray, anything above, I think it's 55 or 65, whatever the CAD for TB score is, going to be referred for gene expert testing. And we have a way to pre-register basically the presumptive case identified by the CAD for TB score, and then apply our diagnostic accountability to make sure that all of those people that are referred for gene expert testing are actually receiving it. And then we can send the result back down to the Delft folks so that they get a little bit better feedback on every person they referred for the CAD for TB score. What does the gene expert say about that TB for that patient? And then for the positive ones, we can refer them on to the treatment and confirm that that's happening. So there is some movement, at least I know in our company, linking the X-ray with the gene expert confirmation. Also, you know, we're working with some case finding groups like ComCare in Mozambique, and some different private pharmacy groups that are doing a kind of questionnaire algorithm to identify potential TB cases. And again, to refer them for gene expert for testing. We're kind of linking up at that point of when they identify the presumptive case and what happens after the gene expert test. So it is in the works, and those integrations are beginning.
Well, that's great. I mean, now that I've seen these presentations, I've now got some names to refer to when we go to reviews and need to make recommendations about which direction to go. I mean, I think the schemes that you're putting out have tremendous advantages, particularly this diagnostic and treatment accountability component. So thank you very much, and we may well be in touch if I ever get to do another mission.
If we all ever get out there again. Yeah.
Okay, so we are at time, but before I provide my closing remarks, I'm wondering if there are anybody who would like to ask some final questions or make any final comments. You can see that Sahu and Chris have added some comments to the group chat. But if there's anyone who would like to make any final, ask Chris, Patty, and Brad some final questions before we close, please do so now or forever hold your peace.
Hello.
Oh, Elaine. Oh, you're a woman. Yes. I'm so sorry. No, like that French spelling, I can't tell sometimes, but maybe the E should have told me otherwise. So Alain, please, the floor is yours.
Thank you. I would like only to comment two things from my experience working with GX Alert and some our challenge project, which we closed this year. I would like to advise one of our colleagues who asked how to upgrade platform from 4.0 to 4.7b or more. I know that CFAID don't have representative everywhere. What we have done in many countries where we don't have country representative, we try to work with CFAID remotely to support the country by sending the CD, which will be used by the people, the master trainer at the country level, what we call super users. And what you need to know is that during the process of upgrading the CFAID platform, you need to plan at least 2 to 3 hours where the machine will not be working, which means that the sample collection or the preparation have to be done upfront. And it will take 1 to 2 hours to upgrade the platform. Before to do that, you need also to take all the data in a supportive CD or any relevant material to be sure that if there are any crash after that, you don't lose your data. And also you need to be sure that if you have only, you don't have a connectivity with a lab informatics system, this will need to have specialized IT people to support the upgrade process. Then it will depend at the country level to the connectivity, also the internet accessibility, because all these have to be prepared on time. I would like to stop there, but it's only to say to my colleague that you can approach CFAID remotely, they can support you, but first you need to have the supportive material, which is a CD, which is free of charge, which will be sent by CFAID to your lab network according to the number of machines you have in the country. Thank you.
Thank you, Alain, for your inputs. Chris, Patty, Brad, do you have any reactions to what Alain has said?
I think she's right, and you know, you just have to make sure those machines get upgraded.
Okay, great. So before we close and everyone goes off wherever, I do want to thank Chris, Patty, and Brad for your presentation and for being able to really transparently and honestly ask or answer the questions that were asked. I also want to take this opportunity to thank everyone who joined. We do this really because I personally believe that TB is a pathfinder. The technologies, the solutions that we have been looking at to fight TB, but how they also apply for COVID-19 other diseases is incredible. But the one thing we always have to remember is as you are actually working with countries to implement these technologies, remember not to forget about TB. I mean, let's be efficient, you know, let's just address TB, COVID-19, HIV, the other diseases all together. There's no reason why we need to do this one disease at a time in a vertical fashion. So that's my point. But I do want to share an exciting lineup that we have for the next Virtual Innovation Spotlight. So bear with me. Okay, perfect. I don't know if, can people see my screen? Can someone say yes, so I know that you can see my screen?
Yes, we can see it.
Okay, perfect. So you can see the upcoming schedule. We have another session around connectivity coming up in 2 weeks. And then after that, we have a session around community-led monitoring, which I think is very critical because that is where you're getting like real-time information, just raw data in terms of what is going on the ground. And I think this feeds into what will happen downstream. So I think this is like really critical, so I really encourage everyone to join. And then we have a series, because it will be not just this one, but we will also highlight the digital adherence technology, particularly this integrated DAT platform that I think is even now more critical in this current COVID-19 situation, because how do you do dots when you're asking people to stay home? But beyond that, it's a really great way to also monitor, support people affected by TB remotely. So I would really advise you to join all 3 of these sessions. We're gonna have more, and we have some actually quite exciting lineups coming up. So I think with that said, I'm going to close this virtual innovation spotlight. I want to thank everybody. If you have any questions, comments, the way we can even improve this, I would actually really love some more pub quiz questions, because this one I think I did not do such a great job, because as Ken said, I revealed the answer. You know, this is for all of you. So if you have anything we can do to improve, to serve you, to make things better, please email us, me directly. But with that said, thank you so much for joining, everybody. Bye.
Bye-bye.
Jackie.